hospital with a case stem. We have a 45-year-old man coming in with a history of type 2 diabetes, and he's admitted for right lower extremity cellulitis. He was prescribed clindamycin by his PCP 2 days prior, but the infection has not improved. His medications include metformin, semaglutide, and lisinopril. His vitals are all within normal limits, and his labs are unremarkable. His blood glucose is 170, and his creatinine is 0.9. So the question today is, what do you do with the metformin on admission? I'll give folks a second to think of an answer. And commit. And I am going to argue today that in this particular case, we could continue it during his admission. So it begs the question, why do we routinely hold metformin for patients with type 2 diabetes when they come into the hospital? And the concern here is often, if I ask all of you, you would say lactic acidosis. So that also begs the second question is, where does this concern for metformin-associated lactic acidosis, or MALA, come from? So to understand this, we have to know a bit about metformin, which is a biguanide. It was discovered in the 1920s, but its use was actually eclipsed by that of another important diabetes medication discovery in the 20s, which was insulin. So it was largely forgotten. Its mechanism, it increases insulin sensitivity in the peripheral tissue, and it decreases hepatic gluconeogenesis. And it's first-line therapy in type 2 diabetes because it's inexpensive, it's weight neutral and often associated with weight loss, and it has a very low risk of hypoglycemia. In the 1950s, there was resurgence of interest in the biguanides with fenformin, which was introduced into the market, but actually pulled in the 70s due to fatal lactic acidosis. And the reason this has to do with the differences between fenformin and metformin. Largely this large lipophilic side chain there on the end, which increases the length of fenformin and decreases its the half-life of fenformin and decreases its clearance. Metformin, in contrast to fenformin, is freely excreted by the kidneys and has a half-life of only 4 hours, and so much less likely to cause lactic acidosis. For this reason, though, metformin was actually not approved in the United States until the 90s due to fears of everything that happened with fenformin. It is a mechanism by which biguanides can increase serum lactate levels, where they interfere with mitochondrial transport and actually block pyruvate here, shunting it towards lactate. However, clinically, this is often not significant, as the kidneys and liver can easily handle the increased lactate load. So how often and when does metformin-associated lactic acidosis occur? It's very, very rare. Most of the data regarding MALA actually comes from case reports. In most cases, with the exception of metformin overdoses, where it's estimated that you need to take about 20 grams of metformin, you need to have some other lactate producing condition in addition to the metformin to contribute to the lactic acidosis, such as heart failure, liver failure, sepsis and septic shock, and most importantly, kidney failure. There was a large Cochrane review done in 2010, which looked at 347 studies of folks with normal renal function and found that there were actually 0 cases of lactic acidosis associated with metformin, despite over 70,000 patient years of metformin use. So to answer our question, can we continue metformin in the hospital? We reflexively stop it, but I would argue here, and the guidelines on this are unclear. Most endocrine society and diabetes guidelines recommend the use recommend against the use of oral agents, just because there is very little data to support the use in hospitalized patients. However, I would argue that a common sense approach here should prevail, and that we need to consider individual patients. So we should look at their renal function, right? We need to hold metformin if they have AKI or at severe risk for AKI, or the GFR absolutely need to hold if the GFR, is less than 30. We need to assess if they're at risk for lactic acidosis. Do they have some other lactate producing condition, such as I mentioned before? If they're really sick, it makes sense to hold it and then restart it when they're doing better. And I think the final consideration for hospitalized patients is there other therapy for diabetes that we're going to be using in the hospital? One of the reasons to continue metformin, and it was recently the routine use of stopping metformin in hospitalized patients was billed as a thing we do for no reason by the Journal of Hospital Medicine, is that we often stop oral agents, and then place patients on sliding scale, which leads to poor control and often leads to is associated with increased length of stay. And metformin may help in those situations. So to summarize, metformin use in the hospitalized patient, we'll look at the mechanism of metformin. It increases insulin sensitivity. It decreases gluconeogenesis. All biguanides can convert pyruvate to lactate, but this is clinically not significant. And lactic acidosis is very rare with normal renal function. And to consider before prescribing metformin in the hospital, 3 things: the renal function, the patient's risk for lactic acidosis, and what other diabetes therapies we may be using in the hospital.